Hello and welcome to this lecture. Today we are going to discuss next series, which is urinary system disease. So what is glomerular disease? It is a disease that affecting the glomerulus that consists of clinical important categories of the renal disease. This is a structure that how glomerular structure look like. The most important thing in the glomerulus is actually this section which consists of podocyte foot processes, endothelial basement membrane, and actually most of the disease are linked to the either with the problem with the podocytes or with the basement membrane. And because these are the site that is responsible for the filtration of the material, absorption of the glucose or salt or iron, and prevent the elimination of the lipids. So that is very important in journal. This is another picture of electron microscope showing you the presence of different components such as this one. E and D stand for endothelial, and then we see that B stand for basement membrane. You can take a look of the normal structure. Then EP stand for visceral epithelial cells. We also discuss in terms of podocytes. Then we have Cl, which is the capillary lumen. So this is a normal low power electron microsgraph that's showing you the normal architecture. And this architecture will be disturbed in this classification in different diseases, like there are nephrotic syndromes that consist of minimal change disease, focal segmental glomerulosclerosis, membrane nephropathy, or membranoproleferative glomerulonephritis. Or we have nephrotic syndrome that consists of post-streptococcal disease or post-streptococcal infection, glomerulonephropathies or IgA nephropathies. Then we have rapid progressive glomerulonephritis, and last is the tubulointerstitial nephritis. We will discuss each of them in upcoming lectures, but today we are going to discuss the nephrotic syndromes. And we are going to start nephrotic syndrome. I am presenting the case of a 42-year-old woman who had proteinuria for approximately 5 years, developed renal failure. She has also developed hypertension and had several bacterial and vaginal yeast infections over the last 10 years. Her 2 pregnancies were uncomplicated, although she required cesarean deliveries for large babies of 9 pound and 9.5 pound. A kidney biopsy reveals increased mesangial matrix and acellular periodic acid skiff positive nodules. Nephrotic syndrome resulting from diabetes, glomerulosclerosis would be likely to be diagnosed. So let's discuss the nephrotic syndrome. The key characteristic of the nephrotic syndrome is massive proteinuria with the daily protein loss in around the 3.5 gram or more in adults. The other characteristics are hypoalbuminemia. Obviously, when there will be the loss of protein, albumin is itself also a protein. So what happens? The loss of protein will result in loss of albumin, and albumin is very important structurally and playing a number of multiple functions in the body. So hypoalbuminemia occur less than 3 gram per deciliter. Then a generalized edema will be found along with hyperlipidemia and lipiduria, and that will be the key characteristics. The cause of nephrotic syndromes are varies in children and adults. If you take a look of this table, there are different type of glomerular diseases such as membranous nephropathy, minimal change disease, focal segmental glomerulosclerosis, membranoproleferative glomerulonephritis, IgA nephrotic, and others. And if you take a look of the comparison between children and adults, different diseases are common in different people. Like the minimal change disease is more profound if you see in children as compared to adults. Whereas if you take a look of the membrane nephropathy, which is more common in adults, along with focal segmental glomerulosclerosis. So the prevalence of the disease varies from children to adults, and different type of nephrotic syndromes occur with different people. What will be the cause of nephrotic syndrome? There will be a number of causes. Diabetes is one of the cause, then amyloidosis, systemic lupus erythematosus, Uh, the primary thing is that there will be a number of other causes that is responsible for nephrotic syndrome. Among them, diabetes is very common. The primary glomerular lesions in the nephrotic syndrome is further classified into minimal change disease and focal segmental glomerulosclerosis. Let's discuss one by one. When we discuss minimal change disease, it is a disease of the children. As if we see the table before, and we mentioned before that minimal change disease occur mostly in children. So this is the disease of the children, and in this case there will be the diffuse effacement of podocyte food process when viewed under the microscope. What is meant by diffuse effacement of podocyte food process we will discuss in next slides. Common between one age to 7 year of age. The common age between 1 and 7 years age, stimulated by proteinuria and podocyte damage and effacement of food processes. Why we call this disease a minimum change disease? Because usually the glomeruli is appear normal under the light microscope. Under the light microscope, what is the site of the problem? The site is actually proximal convoluted tubules. Why? Because at that site there will be the protein droplets and lipids. It is the proximal convoluted tubules are heavily laden with the protein droplets and lipids. When we take a look of the anatomy of the structure, we need to see that the cuboidal epithelium or proximal convoluted tubules may have mitochondria and microvilli. So they have mitochondria and microvilli that is responsible for active transport following the passive transport from the tubules to blood. And if you take a look of the picture, and these small characteristics of the microvilli are present. This is a lumen. Then these are microvilli, small structures. If you zoom this structure, they are presence of microvilli that are responsible for absorption. Then we have mitochondria as well. Then we have nucleus as well. And if you take a look of the structure, that we know that this is the proximal convoluted tubule, and actually they are responsible for the reabsorption. What is the function of proximal convoluted tubule? The main function of proximal convoluted tubule is it reabsorbs filtered glucose into the peritubular capillaries. And the mechanism of glucose reabsorption actually is the main function. And it also responsible for reabsorption of 65% of filtered water, sodium chloride ions, and potassium ion. So it means that proximal convoluted tubules not only absorb glucose, but they are important for the absorption of sodium chloride ions and potassium ions. So that is why this is very important. So what happening that under a light microscope, actually this is the silver methylamine stained glomerulus, and you cannot able to understand what is going on here. But the main thing is that if you take a look of figure 2, the central part is actually, this is the glomerular basement membrane. This is actually the filtration slit. And we mentioned there foot processes for podocytes, blue and green. So actually these are the foot process, and they appear like a foot in structure. They look like a foot-like structure. So that's why we mentioned the name foot processes of podocytes. And actually they are responsible for filtration, for the absorption of ions and glucose. If you take a look of back, we also have the endothelial cell with fenestra. Fenestra mean porous-like structure. It's just like a funnel that is responsible to know that which thing you need to go, which thing is not need to go. So it just like act as a filtrate. and the process of filtration occurs through that surface that consists of foot podocytes, that consists of endothelial cell with fenestra. And what happening in this disease, actually they will be thinning of that surface. That is why I have not explained, because they mentioned diffuse effacement of podocyte foot process. So actually the disease occur in that structure where the foot processes become thin, and that is why the changes that are going to be happen is not easily observable under the light microscope. If you take a look of this under light microscope, maybe you unable to understand what is these all going on. But inside actually the cell, when you zoom it or when you take a look of more close structure, there will be, the main thing is that the filtration slit, that you can say the diaphragm or the opening, whatever the name you want to give, becomes slightly thin. And it, because of this, then more lipid molecules can cross easily to go out, because this is actually a filtration barrier, and that filtration barrier only allow to exit certain things. So the lipids must not be go outside, because if lipid go outside, then hypoalbumin, I already discussed, proteinuria, yes, I already discussed. So these things will be happening. So because of the thinning of these barriers, or you can see that like a security guard, that maybe somehow they get corrupted somewhere, in that case then protein loss will be occur, the absorption of glucose and ions will be reduced, and then it affect. If you take a look of again to see more zoom process, again this is the podocyte with foot effacement, and they are talking about this structure, and these foot processes are not performing their function normally, and due to their you can see that they are not functioning properly, then it can lead to the disease. So obliterating the network of arcade between podocytes and glomerular basement membrane. This is another picture of normal basement membrane. Usually the basement membrane is thick, and they mention here that they are quite thick. But what happened if you take a look of this structure? Now take a look of this structure and compare this one with this one. You can find that the basement membrane is now not as thick as before. So that's the main thing you need to differentiate between the under light microscope with delicate basement membrane. You cannot understand with this picture A unless you take a look of this picture B, and I had taken from one of the research article. You can see the basement membrane is actually thickened under the normal circumstances, but when it becomes thin, then it can affect. So this is another picture to explain how the basement membrane look like, and that you have to see that this is the glomerular basement membrane, and this basement membrane, because they become thin, then it affect the filtration processes. Again, this is another picture to explain that this is the podocyte bridges. These are the podocytes. GBM, this is a glomerular basement membrane, and that GBM will decrease in diameter, and that's why this disease occurs. So this slide is only to see you how anatomically or how the structure look like. Clinically, there will be the insidious development of nephrotic syndromes. Prognosis: more than 90% of the children responds to short-term corticosteroid therapies. So corticosteroid therapy can be given for short-term, because long-term can have the adverse effect, because adrenal suppression occur if the therapy prolonged. And what is adrenal suppression? That adrenal, which is responsible for secreting the hormones, is not producing the normal response. They are not producing the hormones, so it leads to the retardation of the growth. Can reoccur or can regain in 2 to 3 patients, mean that disease can be occur again and again. Less than 5% develop chronic disease even after 25 years. And this is the big evidence showing that this disease occur usually in children and rarely to become chronic after 25 years, but can reoccur during childhood if somebody have fall under this category. Then we have focal segmental glomerulosclerosis, involvement of the focal involvement of the glomerulus. It is a segmental involvement, as the name indicate, focal segmental. Focal mean at certain part or at certain segment. So either it is the focal involvement of certain site or in segments of some segments or certain area of glomerulus. The etiology considered as causing because of the HIV or heroin abuse or the other causes such as IgA nephropathies or inherited or congenital causes has been expected. This is a normal glomerulus, and this is the focal segmental glomerulosclerosis, and you can see this is only affecting on certain section, certain part, not affecting all. The other section are normal. Only this certain side is affected. And what happened, we will discuss in detail. The pathogenesis of is actually the injury to the podocytes is thought to be the initiating event. So what could be the reason? Because of the deposition of hyaline masses in the glomeruli or entrapment of the plasma protein. So the main thing is that the plasma protein will be get trapped inside the glomeruli, and then it appear as a hyaline mass, and then obviously when the plasma protein will be deposited, then it can leads to the injury where sclerosis or develop. The other thing that is found that the production of IgM and complement protein is the key pathogenesis in the disease. So if we need to diagnose the patient with focal segmental glomerulosclerosis, we need to check the complementary protein level or the IgM production. This is the picture of focal segmental glomerulosclerosis, and they are showing you the segmental deposition of the hyaline membrane and lipid in the sclerotic area. So you can see the round structure. They are showing you the presence of the lipids that is entrapped inside the glomerulus, and they are showing you only in certain segments with the presence of hyaline masses and the formation of the foam cells. What foam cells look like? Foam cells are actually lipid droplets that containing mitochondria, endoplasmic reticulum, and then their lipid droplets is showing you the entrapments of the lipid inside. Morphology, the affected part, usually they're talking about the juxtamedullary glomeruli, and it later on eventually affect all level of the cortex. So the site of action is the cortex, with having increased mesangial matrix, obliterated capillary lumina, deposition of the hyaline masses. I already discussed why matrix increase because of the lipid deposit. Why obliterated capillary lumina? Because obstruction, because of the lipid droplet. Then deposition of the hyaline mass is the key characteristics. Again, this is a picture to compare the normal glomeruli and in focal segmental. Normal glomeruli, you can see that only 1 or 2 cells, capillary lumens are open. The glomerulus is thick. There is no any certain area where you can see the presence of hyaline membrane. But when you take a look of the focal segmental, it can affect and producing the hyaline masses, and it is on a certain section site. This is the picture, anatomical picture, to explain again how the glomerulus look like, just for the information. And this are the podophyte food processes. These are, you can see that mesangial. Then we have the cavode. These are the glomerulus capillaries, and then they are responsible connected with distal tubules. So you have to understand this is the anatomy of the structure. I'm not going to see again. This is another picture to take a look of anatomy of glomerulus. I'm just skipping that slide. So the morphology is the collapsing glomerulopathy, collapsing of the glomerular tuft, and podocyte hyperplasia. So there will be enlargement of the podocytes and then collapse of the glomerular tuft. The clinical course will be that there will be increase of the hematuria and there will be hypertension. The response to corticosteroid therapy is poor. 50% with their focal segmental glomerulosclerosis develop end-stage kidney disease well within 10 years of diagnosis. Again, this picture is showing you that how the structure look like, so you can read for your own information. And what happened when podocytes actually hypertrophy? You can see that because of the enlargement, they detach from the surface. So that's just going you to see you that how hypertrophy occur. Then we have membranous nephropathy, which occur usually at the age 30 to 60 years of age, and they are characterized by the presence of subepithelial immunoglobulin containing deposition of glomerular basement membrane. And the main thing is that 85% of cases caused because of the autoantibodies that cross direct with antigen. So actually the antigen and antibody reaction is one of the responsible, and that is why we mentioned that the presence of subepithelial immunoglobulin that containing glomerular basement membrane is a characteristic. Causes actually this not primary causes, mostly are secondary causes like hepatitis, syphilis, schistosomiasis, malaria, tumors, carcinoma of the lung, colon, melanoma, autoimmune disorders such as systemic lupus erythematosus or autoimmune disease I already discussed, exposure to inorganic salts such as gold, mercury, or sometimes the drugs that leads to the membranous nephropathy. And actually, it is characterized more like a autoimmune disorder. And what happened that it is a chronic immune complex and glomerulonephritis, as what happened that autoantibodies and autoantibodies and antigen react in the glomerular capillaries and form the immune complex, and that immune complex occur because of that receptor phospholipase A2, and that responsible for that autoimmune complex for proteinuria without severe inflammation, because it is an autoimmune disorder, not inflammatory disease. So that is where in how can you diagnose the key characteristic that there will be no inflammation but there will be proteinuria with immune complex formation. How that process occur? If for example any hepatitis occur, any viral infection occur, and it triggered the immune system, then what happens, there are some certain protein like C5b and C6, they bind on the surface of the bacteria, and then after that the binding of C6 to C5b activates C6 that can bind to C7. So it is a chain reaction, and this picture is showing you that C5b binding with the C6, this is a C6, and that activated the binding of C7, and then it activates C8 and C9, and this is a series of steps that is responsible, and together with these protein they form a circular complex known as membrane attack complex. And the membrane attack complex formation is actually leading to the formation of pores and channels, causing the lysis and cell death to target. So again, the main thing that because of the activation of the complement system from C5 to C6 to C7 and 8 and 9, they activating the complex which is known as membrane attack complex, and that membrane attack complex increase the porosity channel formation that is responsible for the initiation of cell death. So it is a autoimmune disorder. When we take a look of the morphological characteristics, we found that the podocyte effaced food processes, there will be again the thinning of the podocytes, but there will be the thick basement membrane found. This is the basement membrane. So this basement membrane is thick than normal circumstance. Why? Because of the activation of the complement system. And then we found subepithelial deposits, that black, they're showing you the presence of subepithelial deposits, and they are the presence of spikes, means they are present at regular intervals and they are responsible for that. And the characteristics are thick basement membrane and then the subepithelial deposits. And why this occur? Because of the deposition of the immune material. So we mentioned that diffuse capillaries. Why? Because of epithelial deposits and then effacement of the food processes. So again, this picture to showing you that These round structure is showing you the presence of the subepithelial deposits. And why? Because of the immune malfunction. Then food process fusion. This is the food processes. They are widely separated. Here you can see. But what happened here, if you take a look of between these two, or between these two, or between these two, the space between two food processes become reduced and they become narrowed close together. This is a normal picture. So you can see this happen in the disease. In clinical course, in contrast to minimal chain disease, the proteinuria is non-selective with urinary loss of globulins as well as smaller albumin molecules, and does not usually respond to corticosteroid therapy. So the therapy is not effective with corticosteroids, or corticosteroids are not effective, and then there will be the urinary loss of the globulin as well as small albumin molecules. Then we have membranoproleferative glomerulonephritis and dense deposit disease, which occur because of the alteration of the glomerular basement membrane and the mesangium and the proliferation of the glomerular cells. It has been classified into two types. One is MPGN1 and MPGN2. When we take a look of the pathogenesis, it is caused because of the immune system or formation of the circulating immune complex, caused because of the hepatitis B and C. Antigemia means the viral infection or autoimmune disease such as systemic lupus erythematosus or infected arterioventricular shunt or extra-renal infection persistent with episodic antigemia. The type 2 MPGN is caused because of the dense deposition of the disease caused because of the excessive complement activation. Again, the excessive activation of the complement system. So what happened? The glomeruli are large with large lobular appearance. Proliferation of the mesangial and endothelial cells as well as infiltrating leukocytes will be formed. The splitting of the glomerular basement membrane occur due to the extension of the processes of the mesangial and inflammatory cells into periphery capillary loops and deposition of the mesangial matrix. So that will be the key characteristics. If you take a look of type 1 MPGN, you can see the dense deposition, subendothelial deposition will be found, and intramembranous deposition also found, that it is present either at intramembrane, between the membrane, or it is present as subendothelial deposits. This is another picture that showing you the presence of the thickening of the basement membrane, leukocyte infiltration, and changes in the lobular architecture. When we talk about the clinical causes, the prognosis of MPGN type 1 is generally poor. None of the 60 patients followed for 1 to 20 years show complete remission. 40% of progress to end-stage renal failure. 30% had variable degree of renal insufficiency. 30% have nephrotic syndrome without renal failure. So what are the learning outcome for this topic? We described the glomerular disease and its classification, discuss different type of nephrotic syndromes, discuss the explanation and morphologic pathogenesis and clinical features of different type of nephrotic syndrome. So thank you so much for today's lecture. Hope to see you again.